Hi, I'm Dr. Kristina Dervaitis, a gynecologist in Newmarket, Ontario, Canada. Welcome back to my channel, Talking IUC with Dr. D. Now, in today's video, I am going to be talking about the intrauterine device, but more specifically, the hormone-containing IUD or IUS intrauterine system as it's known. So today we're going to be talking about specifically about the 52 milligram levonorgestrel intrauterine device and its application for treatment of something called endometrial hyperplasia. Now, in talking about using the levonorgestrel IUD for treatment of endometrial hyperplasia, first, of course, we will need to talk about what exactly is that. What is endometrial hyperplasia? And actually, I'm happy to have this opportunity because I've had several viewer comments recently asking about use of the hormonal IUD for this indication. So endometrial hyperplasia. So first of all, the word endometrium applies to the glandular inner lining of the uterus. And so that's the lining that grows and then is shed each month as part of menstruation. So that's the endometrium. So the term endometrial hyperplasia means overgrowth of the lining of the uterus. Now, what causes the overgrowth of the lining of the uterus? What are some of the risk factors for this condition, and what can happen if someone has endometrial hyperplasia? So to back up a step, in terms of factors that can affect the growth of the lining of the uterus, the main ones are the hormones estrogen and progesterone. So those are the two main hormones that are part of the menstrual cycle. And I usually use the analogy that estrogen is sort of like the fertilizer, if you will, and progesterone is like the lawnmower. Humor me with this analogy, but it tends to work. So lifelong, if you are in a situation where you're getting lots and lots and lots of fertilizer, but not enough of the lawnmower coming in to clear things, then that can be a setup for overgrowth of the lining of the uterus or endometrial hyperplasia. Some potential scenarios that can lead to that situation of too much estrogen and not enough progesterone, which is the root cause here. One situation can be what we call anovulation. So ovulation and regular healthy menstrual cycles are important for triggering the production of progesterone. So if someone who is not on the birth control pill, who is not using a hormone-containing IUD, if someone is having very infrequent menstrual cycles or no menstrual cycles at all, it means that they're not ovulating, and that lack of ovulation can lead to lack of progesterone production, and that can cause a lifelong imbalance between estrogen levels and progesterone levels. Another situation that can be a setup for too much estrogen, not enough progesterone, is actually obesity, in that patients who have a BMI that is above average or not in the ideal range. If someone has a high BMI, the actual adipose cells or the fat cells in the body produce a form of estrogen. And so that external production of additional estrogen, which normally is mostly just produced by the ovaries, but that additional adipose tissue or fat tissue production of estrogen can lead to a situation where you have too much estrogen and not enough progesterone. So in those patients with a high BMI, they may still be producing progesterone, they may still be ovulating, but there the imbalance is caused by an overproduction of the estrogen by that fat tissue. So that's another potential situation where we can see overgrowth of the lining of the uterus. There are some additional unique situations such as patients who are on a medication called tamoxifen, which is used in treatment of certain forms of breast cancer. Tamoxifen use can be a risk factor for endometrial hyperplasia. It's a bit of a subset conversation of this bigger picture. I'm not going to get too much into tamoxifen and its effects on the lining of the uterus, but to state briefly here that tamoxifen use can be a risk factor for endometrial hyperplasia or overgrowth. And then lastly, there are some situations, some family syndromes and genetic syndromes that may predispose to endometrial hyperplasia or endometrial cancer, most specifically something called Lynch syndrome, which again, I'm not going to go into a whole lecture on that here, but simply to list it as one of the potential risk factors. What symptoms might someone have if they have endometrial hyperplasia? Probably the commonest symptom that we would see is dysfunctional bleeding or abnormal bleeding. Now, in someone who has not yet reached menopause, that could be anywhere from heavy bleeding, bleeding in between periods, prolonged bleeding, basically a new pattern of bleeding that's different than previous. Sometimes we can even detect it in patients who don't have a dramatic change in their bleeding necessarily. So having normal periods doesn't absolutely rule this out, but certainly in patients who present with a change in menstrual bleeding, such as prolonged bleeding, bleeding for weeks at a time, bleeding in between periods, heavier bleeding than usual, in those situations, we would consider testing for endometrial hyperplasia. In a postmenopausal patient, so someone who has gone officially 12 months without a menstrual cycle and is officially menopausal, if there is any bleeding after that point, so after the 12 months of no menses, if there is new, what we call postmenopausal bleeding, then in that situation, we would definitely investigate for endometrial hyperplasia. Now, not every patient who has postmenopausal bleeding necessarily has endometrial hyperplasia or overgrowth of the lining of the uterus. There are several different potential causes for postmenopausal bleeding, many of those causes being benign. But in this scenario, we definitely would do further investigations to rule out any sort of overgrowth of the lining of the uterus. So in terms of how do we then go about and make the diagnosis of endometrial hyperplasia, this is usually done using what's called office endometrial sampling or an office endometrial biopsy. And I'll just grab a biopsy pipelle so that I can show you what that looks like. So here I am back with an endometrial biopsy pipelle. So you can see, if I bring it up close, this is in the plastic wrapper, it's very narrow tube. This end is inserted into the cervix and through up to the uterine cavity. So first a speculum exam is performed, so similar to a pap test. And then this tiny little tube quickly goes into the uterus to take a sample of tissue by pulling back on this portion of the biopsy pipelle. There's suction and we're able to get a sample of tissue. And usually it takes about 10 seconds of admittedly fairly intense cramping, but after that 10 seconds, usually the cramping subsides fairly immediately. And just as a forewarning, you might have a little bit of bleeding or spotting after that sampling. The tissue is placed into a container of formalin and sent off to the lab so that a pathologist can look at the cells under the microscope. And usually we get those results within 1 to 2 weeks where I'm practicing. Now, in terms of after we've done a sample, if the results do come back showing overgrowth of the lining of the uterus or endometrial hyperplasia, what does that mean and what are the next steps for treatment? So first of all, it's important to emphasize that hyperplasia or overgrowth of the lining of the uterus does not necessarily mean uterine cancer. So hyperplasia means overgrowth of the lining of the uterus. Neoplasia or cancer means uncontrolled growth or out of control growth, and that's sort of a separate situation. Hyperplasia, if we left it long enough and didn't provide proper treatment, could progress to neoplasia or cancer, could progress to uncontrolled growth. But of course, the whole reason that we're doing this screening and treatment is to make sure that things never transition all the way to cancer. So this is sort of a, I hate to say the term pre-cancer, but definitely different from cancer and very treatable in order to prevent progression to cancer or uncontrolled growth. So it's important to understand that there are two different kinds of endometrial hyperplasia. There's endometrial hyperplasia without ATYPIA and endometrial hyperplasia with ATYPIA. Now, ATYPIA is a term that is used to describe what is going on within the inner nucleus of these endometrial cells. So hyperplasia just means enlargement of the gland itself, which is made up of many cells. And with or without ATYPIA has to do with what's going on inside the actual nucleus of those cells, if they're starting to show abnormal changes. If there are abnormal changes within the nuclei, the center portion of those cells, it is considered ATYPIA. If those changes are not yet present, it is considered without ATYPIA. Now, the importance or the reason for this distinction is that treatment options are very, very different depending on whether or not there is or is not ATYPIA. In a situation where there is ATYPIA, there is a slightly higher chance of progression to cancer, and so the treatment options are different. So the range, we previously had 4 categories for ATYPIA. I won't get into that historic reference, but I will say that based on that previous categorization, we knew that the risk of hyperplasia with ATYPIA could range from as low as 3%, but up to as high as 27%. So in those situations, we're a little bit more aggressive in terms of how we manage things. And right now, the standard of care would be to offer that patient a hysterectomy, usually involving also removal of the fallopian tubes and ovaries, but depending on the patient's menopausal status. If they were postmenopausal, definitely removal of the ovaries as well. Premenopausal, there might be a debate or a discussion with that patient's healthcare provider as to whether or not to leave the ovaries in place or to go ahead and remove the ovaries. And that's sort of a longer separate discussion, not really the purpose of today's video, but just to briefly talk about treatment of endometrial hyperplasia with ATYPIA. Endometrial hyperplasia without ATYPIA is treated basically with progesterone. The risk of progression to cancer is much lower. It's less than 10%, anywhere from 1 to 9%, based on the previous categorizations and data that we had with regards to that. But basically, a much lower risk of progressing to cancer if left untreated, and very responsive to treatment with progesterone. So again, we said estrogen is sort of like the fertilizer. Progesterone is like the lawnmower that cuts down that extra endometrial tissue. So that's why we use progesterone in this scenario. Previously, when we were treating endometrial hyperplasia without ATYPIA, the standard of care was to first start with oral progesterone or oral medications, generally prescribed for a period of time of up to around 6 months. And then the patient, after having had that 6 months of treatment, would return to the office for a repeat endometrial biopsy to confirm that the endometrial glands had gone back to normal and were no longer showing any signs of overgrowth or hyperplasia. More recently, we've had more and more experience with actually using the LEVONORGESTREL IUD, 52 milligrams, so either Mirena or Liletta, depending on where you live, and that there actually has been good evidence to show that progesterone delivered to the lining of the uterus in this fashion is very effective at reversing the effects of endometrial hyperplasia and can be used as treatment in this circumstance. And now the reason that I decided to do this video is that just this past month in the Canadian Journal of Gynecology, Journal of Obstetrics and Gynecology of Canada, JOGC, this is December 2019, actually published a guideline with regards to endometrial hyperplasia, and has now come out saying that not only should the levonorgestrel IUD be a consideration for a form of treatment, but that it actually should be considered first line treatment. So our first line go-to treatment for endometrial hyperplasia without ATYPIA. And when you think about it intuitively, this makes a lot of good sense, because in this scenario, the progesterone needed to treat the hyperplasia is being delivered directly to the lining of the uterus with the small T-shaped IUD that's inserted. And the insertion process is very similar to having had the endometrial biopsy. So in most patients who we've been successful in the office in doing an endometrial biopsy, it's usually fairly simple to be able to insert the IUD. So one advantage is direct delivery to the lining of the uterus. The second advantage is that because the hormone is delivered directly to the lining of the uterus, there tends to be very little absorption into the bloodstream and fewer hormonal side effects. And I've discussed this in previous videos, so I'd refer you back to my Talking IUC with Dr. D video library for more information on potential side effects. But again, with this delivery method, it's ideal because the progesterone is going to where it needs to work, and less of that progesterone is having to travel through the bloodstream to other organ systems. Of course, the other convenient advantage of the levonorgestrel IUD or IUS is that it once it's in place, the patient doesn't have to remember to take a pill every day. And in this instance, it's approved for use for up to 7 years when we're not relying on it for contraception, and even if we were relying on it for contraception, if the patient were at least age 44 or 45 or greater, then the IUD can stay in place for up to 7 years. Now, part of the protocol would be after initial treatment with whatever method is chosen, but if in this instance we're choosing to start with the levonorgestrel IUS as our first line option, it is still possible to, say, 6 months later, repeat the endometrial biopsy. The IUD being in the uterus doesn't interfere with that. We can repeat the endometrial biopsy and check to see that our treatment has been successful. And now once we down the line have repeated the endometrial biopsy and confirmed that treatment has been successful and that the gland tissue has gone back to normal and not showing any signs of overgrowth, usually the recommendation would be to simply leave the levonorgestrel IUD in for the full duration so that patient can continue to receive the benefits from that progesterone, which would continue to be there protecting the lining of the uterus from any future development of hyperplasia. Now, say that patient has successfully undergone treatment and it's 7 years later and it's time for the levonorgestrel IUD to be removed. What next? And is any further treatment necessary? Now, there's not necessarily firm guidelines with regards to long-term treatment, but I would say that things would be individualized. So based on that patient in particular and their individual risk factors. For example, if a patient is significantly obese at the time that I'm removing a Mirena IUD, I know that that patient is still unfortunately at risk for overgrowth of the lining of the uterus because of the additional estrogen in the adipose tissue. Of course, we counsel that weight loss and attempts at weight loss are critical as part of the big picture. But bottom line is, if that risk factor still remains, then in that patient, I might elect to offer another levonorgestrel IUD as further preventative treatment in someone who has an ongoing risk factor for endometrial hyperplasia. Similarly, in terms of guidelines, there aren't really strong guidelines or specific guidelines as to the frequency of repeat endometrial sampling or repeat endometrial biopsy. Definitely initially we tend to do more repeat biopsies just to confirm successful treatment. Down the road, whether or not further endometrial sampling is necessary would depend on the overall clinical picture. Obviously, whether or not the patient is continuing to have abnormal bleeding, or in a postmenopausal patient, if they've developed any new concerning postmenopausal bleeding. So again, it would be sort of individualized based on the patient, their clinical history, their potential risk factors, how often I would be performing repeat endometrial sampling in the future. So that was basically a video that was prompted by the recent Society of Obstetricians and Gynecologists of Canada, their December 2019 guideline regarding endometrial hyperplasia management. And although we had been previously using the LEVONORGESTREL IUD for this indication, the guideline has actually come out and said that the 52 milligram LEVONORGESTREL IUD should be considered a first-line go-to option when it comes to treating endometrial hyperplasia without ATYPIA. And actually a similar guideline existed in the UK from the Royal College of Obstetricians and Gynecologists several years ago, but this is the first time we have a Canadian guideline stating that. So I thought it was important to do this video and just speak a bit about the use of the LEVONORGESTREL IUS for this indication. So that's all for today's video. I will end the video as I always do, that reminding you that in just 5 minutes an IUD can be inserted and last up to 5 years, or in this case, for this video, I mentioned the 7-year duration of use, but that's all for today's video. If you have any questions or comments, please feel free to send a comment. I try to answer as many as possible. Thanks for watching, and we'll see you in the next video. Take care.